Hello, Sachin sir.
How you doing?
Hi.
Yeah,
Hi, Jayesh.
yeah. Good evening, sir. Sir,
Hi,
Jayesh
hi,
sir will
Rishabh.
be. Sir, Jayesh sir will be logging in a bit late.
Yeah, he called me.
Caught up with something.
No issue.
Actually, I've logged in from his ID because the meeting was scheduled from his ID.
That's okay.
Yeah, sir.
Yeah.
आपलं plan कसं
YouTube?
करायचं? You will start presenting and we'll have questions thrown from your side and being put to the residents.
Has anybody prepared a case?
We have prepared one case. But since he did not get much time, so that's a PPT is not up to the mark, is what he was saying. But he can present the case, show a few images of the patient and everything.
No, actually,
excuse me, just for a second before I leave. What's
Yeah.
the YouTube channel? Can you send me the YouTube channel, please?
Yeah, John, I've forwarded you on the WhatsApp thing. I've just forwarded you the.
Okay, good luck.
Yeah.
Bye-bye.
So, Rishabh, what I feel is I have a PPT made,
Okay.
which is actually about how to take a case history in a spine case and arrive at a diagnosis. So that actually is an ideal way of doing things. So I can go ahead with that if you allow, so that the resident will get benefited how to take it, because whatever they have taken, there may be some lacunae which is always
true.
there.
Yes.
So, and then if they wish to present, they can, but I don't think we can flip the pattern sometimes, that I can post some question in between, so to get them involved.
That is right.
But I will go ahead and tell them what the examiner expect from a resident, rather than they presenting and then we finding out mistakes. So I will talk and we'll put.
Chalel, sir. We'll start off with you only.
Okay.
So
let me share.
Yeah, slides एकदा.
It is disabled येत आहे ते, तू बघ थोडं.
एक मिनिट. मला ऍक्च्युअली सर ऑप्शनच नाही आला.
होस्ट बनवावं लागेल तुला. You will have to make me host.
Okay.
Host, probably co-host, JK. Yeah, now I'll be able to present. Is it okay?
Yeah, it is. इथं सर मागं पुढं करून बघा. आहे. Yeah.
ठीक आहे. Okay.
चालेल. We will start in another 5-10 minutes, sir. I think people have just started to log in now.
Once there are 10-15 people, we can start.
Yeah. Yes.
Okay. Yeah.
Good evening, all the respected teachers.
Sachin sir.
मीटिंग है, जूम मीटिंग है, अप्रोच टू ए केस ऑफ स्पाइनल पैथोलॉजी.
Sachin sir, next 5 minutes we'll start.
Yeah, no issue.
Yeah. We'll be starting off in next 5 minutes. So if anybody wants to contact their colleagues or the departmental people or their other residents, their seniors, kindly ping them, message them so that we can have a good academic session today. And I'll request Dr. Arjit and Dr. Kavin to have their videos on during the presentation.
टोपी वाला
तो ऊपर जो लाख पल्ला गुलानी
यार नहीं खबर
लाखों में जोड़े जोड़े आप जैसे रहे हो
खरे करने का एक टोपी वाला होता है कौन जो हम टोपी हेड टाइप में टोपी पहने
Someone.
सर चालू करूया. So
Yeah.
good evening to one and all. This is our fifth episode of Neurosurgery Gurukul, which is under the aegis of Insraf, which is Indian Neurosurgical Resident Academic Forum. On this occasion, I'd like to thank our Dr. Jay Sardara. He's not been able to make it to the webinar today. He'll be joining in shortly in another opportunity to thank and invite Dr. Sachin Borkar, who has been kind enough to take up this lecture for us today. A short introduction to introduce to people who do not know Dr. Sachin Borkar. Dr. Sachin Borkar is an additional professor at Department of Neurosurgery in AIIMS, Delhi. He's finished his residency from AIIMS, Delhi, followed by a clinical observership in neuro-oncology under the renowned Professor Mitchell Berger in UCSF, California. Followed by that, Sir has specialized with fellowships in spine surgery under Spine Asia Pacific Spine Fellowship under Dr. Professor Shankar Acharya at Sir Gangaram Hospital, New Delhi. He's received various awards, a gold medal in MBBS, gold medals in DNB. He's been awarded as the best MCH resident, outgoing resident in AIIMS, Delhi. He was a recipient of Neurosurgery Next Gen Award in 2016 under the aegis of International Neurosurgery Update, which is held in Mumbai, and was also awarded the H. Allen Crockett International Award for AANS CNS Spine Section. He has a total of 154 publications, which includes 44 publications in spine and 21 chapters in different books. He's currently serving as an EC member in Neurotrauma Society of India and member in Delhi Spine Society. He is one of our core committee members at the NSI YNF forum. He is also an editor at JOSS, an official journal of Neurospinal NSSA, spine section editor for Journal of Clinical Orthopedics and Trauma, that is JCOT, and as well as on the editorial board. We have two residents who will be on the student panel. I invite them, Dr. Arjit from Manipal Hospital, Mangalore. He is an 6th year resident of DNB. And Dr. Kavin from Sion Hospital in Mumbai. He is the final year resident for us in Sion under MCH Neurosurgery. I congratulate them and thank them to be on the panel, and best of luck. Do well. I'm very sure you don't need to worry about the presentation part, because that would be taken care of by Sir himself today. So I invite Borkar sir once again. Thank you very much, sir, and over to you, sir.
अंशुमन सर के साथ बैठ कर घंटे गाड़ी में बात की मेरे साथ में.
I'll just make you the host, sir.
Yeah, thank you very much, Rishabh, for the kind introduction.
Can I request the participants to switch off their mics? Yeah, sir. Over to you, sir.
Yeah. Rishabh,
Yes,
there
sir.
are there is still some background noise. Can you
Yeah.
please switch
Uh,
off from our end?
मैं जल्दी निकल गया आज
Padam sir, can you please switch off your mic, sir?
Okay.
Yes, sir.
Yeah. Good evening, everyone. Thank you, Rishabh and Jayesh, for having me here among the residents for this class on clinical examination in a spine case. So I'll share my screen and we'll talk simultaneously. Is it visible?
Yes, sir.
Yeah. So for all the DNB and the MCH neurosurgery trainees, and the exit exam is actually still based on a long case and a short cases. And each of you is expected to be mastering this art of clinical history taking and examination to pass in exam. So unlike in the West, where you are probably assessed differently on OSCE and the operative skills, here the workhorse of examination in our setup is again the long case and short case. So, and as examiners, so we tend to be examiners for MCH as well as for the spine fellowship exams. And what as examiners we expect you should know, I will like to present that so that you will be better prepared next time you take any spine case and present a case. So I will give you what we expect and what approach do we see in residents who is presenting a case. So I am Dr. Sachin Borkar. I am working in AIIMS New Delhi, and I will like to take you through the journey of spine case examination. So the prototype which usually for the long case we decide is either a CV junction or an intramedullary tumor or a high cervical disc, which will actually present a cervical spondylotic myelopathy, which will present something like maybe a multi-level CSM or OPLL. These are the long cases usually we give for exam, and you must have seen these are the common cases which are present in the wards and how to arrive at a diagnosis. So most of the time the long cases in exam will be one spine case and a cranial case, which will be most likely a vestibular schwannoma or a CT angle pathology. So you should be absolutely clear about the CV junction and obviously the vestibular schwannomas, which may be covered in subsequent lectures under this series. But I will take you to the spine case, and the prototype which I have taken is actually a CV junction anomaly or a high cervical compressive myelopathy. So these are pretty much, you must have seen all these pictures and in your wards, and this is the cases which are given as to you during examination. So foremost thing in any spine case, be it the CV junction or the cervical cord or below, is this cross-sectional anatomy of the spinal cord, and one should be knowing this cross-sectional anatomy very well, because all the clinical diagnosis is based on this cross-sectional anatomy. So what it is actually important is in the lateral corticospinal tract, which is shown by this red. Yeah, there is some disturbance. I'll request all of you to switch off the mic so that we can have an uninterrupted discussion. Yeah, thank you very much. Rishabh,
Yes, sir. Yeah, I've done that.
Yeah. Yeah, is it okay now? Yeah.
Yes, sir. Yes, sir.
So this cross-sectional anatomy is pretty important, and in a cross-sectional anatomy of the spinal cord, this corticospinal tract, the arrangement of fibers, the sacral are the lateral most and the cervical are the medial most. Similarly, in the lateral spinothalamic tract, the cervical are the medialmost and the sacral are lateralmost. So both the lateral corticospinal and the lateral spinothalamic, the topographic arrangement of fiber is such that the cervical are medially placed and the sacral are the laterally placed. In contrast, in the posterior column, the cervical are laterally placed and the sacral are medially placed. So this has huge implication, because if you take maybe intramedullary tumor which is arising from around this center part of the cord, then the cervical fibers will be affected first, and that is why in any intramedullary tumor or a syringomyelia which starts from the central canal, the upper limbs are predominantly involved compared to the lower limbs. So that is one thing which will guide you. If your upper limbs are disproportionately involved, then you should always think of something intramedullary. So that will give you a clue to diagnosis. Similarly, the pyramidal tracts, the compression, if there is an extradural pathology, maybe like a CV junction, or there is a neurofibroma arising from this roots and it is compressing the cord, what will happen is the sacral fibers, which are the peripheral most, will be compressed first. So the sacral, the lower limb fibers, the lumbar fibers will be affected first, and then the thoracic, and then the cervical. So it will be an ascending sort of weakness, starting from below going up. So each of everything is linked to this cross-sectional anatomy. So you should know this. So the other tracts are also important, but the main tracts are obviously the posterior column, the anterior, the lateral spinothalamic tract, and the lateral corticospinal tract. So you should know this topographic arrangement. Then coming to the history part, obviously you will ask before you start the history, you will ask about the patient name, age, sex, whatever is their occupation, which may be at times be contributing to his symptoms. And obviously the reliability of history needs to be told at times. That gives a good impression to the examiner to start with. And the clinical presentation usually often CV junction or a high cervical spine pathology is actually neck pain, weakness of all four limbs, the quadriparesis, gait instability, sensory abnormalities. These in combination or alone will be the presenting symptoms. Less commonly, the patient may present with drop attacks, neck tilt, or neck clip, and these are by and large the symptoms. This is the landmark paper by Wadia in 1983, which the examiners are quite fond of. So you should always read this paper. And they also told that the CV junction anomaly can present it this way: nuchal pain, drop attacks, progressive weakness, instability, etc. So once you tell the chief complaints, obviously the patient has presented with a quadriparesis or a neck tilt. Then comes the history of presenting illness, which is the in which you will describe each of the complaint. And for any complaint, be it spine or cranial, what I would suggest you should follow this pattern, that any complaint you should tell the onset, duration, progression, aggravating and relieving factors, and current status and current disability because of the symptom. So if the patient has a weakness, obviously it started 6 months back, it gradually progressed over a period of time. Initially, it was just in the lower limb. Then he gradually had difficulty in climbing the stairs, so the proximal muscle got involved. Then he also has difficulty in combing his hairs overhead, keeping things overhead. So there should be a logical progression. And but at this point of time, just progression doesn't make much sense. You should also tell them what is the problem, because the current problem because of this complaint. So whether he is unable, because of this weakness, he is unable to walk, he is unable to go to toilet, there he cannot do his activities of daily living, and he is extremely disabled. He requires support for each of this activity. So this is the way you should present any symptom. And you should always tell the current status and current disability, which usually most of us forget. We just go ahead with the history of present illness, but we do not tell the current status. So that's why a point that you should always tell in each symptom. So, for example, nuchal pain is a very common symptom in a spine pathology or pain as such anywhere. So again, the onset, duration, and progression, nature of pain, what kind of pain it is. It is a radicular pain. Is it a referred pain? It is a shooting pain. Is it a dysesthetic pain? So you should know all kinds of pain which can be there. So most likely it will be either a radicular pain or a dysesthetic or funicular pain. Again,
Ya voy a conmigo tiene que aparecer y que no pueda. Yo sí lo soy esto de uno.
Can I request Sandra? Can you please switch off your mic?
Niña, mándalos para de que era de alimentos que ya, en el segundo ya subo.
Miss Sandra, can you listen to me?
Hola, una pregunta, ¿dónde queda la escalera? Gracias.
Sir, can you mute them, sir? Sachin, sir?
do you have, can I? If I
Yeah, sir. You are the host. You can do that, sir.
Okay. I cannot see any control.
Sir, if you see when you go towards the image, you'll see there are on the right side there are 3 dots. You have to click on the dot and then you can mute it.
No, there is no such option there. But you can be the host and do that, and then I will start again.
Okay, I'll do that, sir.
Yeah.
और टेबल करके देखना है वजह से होगा बाकी सीटी का हुआ है पूरा
Yes, sir. You're the host now.
Yeah. So yeah. So we were at the Institute of Presenting Illness, and I am telling you that you have to present in onset, duration, progression, aggravating, relieving factor, and current status, current disability for every symptom. Then the most common symptom is usually the pain, which you have to tell about whether it's a radicular pain or a dysesthetic or a funicular pain. That will give you, the examiner, an idea that you know how the pain presents, especially in a intramedullary pathology. It will be a funicular sort of pain, a dysesthetic sort of pain, whereas in an extradural pathology, it may be a radicular sort of pain. Then again, aggravating and relieving factors for pain, especially in CV junction, cuff-induced headache, if there is an associated Chiari malformation, if there is a raised ICP, there is hydrocephalus as well. Along with that, then you may have a headache of the raised ICP. And obviously, I'll come to that part later with the resident panelist, how the headache of raised ICP present. Then again, the diurnal variation. This is pretty important because early morning headaches points to a raised ICP, night cries, which is usually seen in tuberculosis of the spine. They are all cases which can be there. So you should know the diurnal variation of pain is also pretty important. And associated vomiting if it's pain of the raised ICP. Then again, weakness, as we have already discussed, onset, duration, progression, whether it's an ascending or a descending weakness. Again, that remember that cross-sectional anatomy of the spinal cord and the lateral corticospinal tract, these fibers, these are sacral fibers, are placed laterally. So an ascending weakness will actually is meaning that there is compression from outside and towards in. Compared to intramedullary pathology, in which it will be a descending sort of weakness, the upper limbs will be involved first and then the lower limb. So you should be knowing, should be able to tell on history whether it's an ascending or a descending weakness, whether it's a symmetrical or an asymmetric weakness. Again, asymmetric weakness is if it starts from one side. Symmetric is more often if it is starting from the center, whether it's involving the proximal or the distal muscle group, predominantly corticospinal innervated groups. We usually are carried away by the upper and lower limb weakness, and we forget the trunk and the neck muscle weakness. So whenever you are saying an ascending pattern of weakness, so after lower limb, you should also be telling that the trunk muscles, if they are weak or not. And how will you ask a history? Dr. Kevin, if you're there, how do you know how to ask for a history of trunk muscle weakness?
We can ask if the patient is having any difficulty in waking up from supine position, getting up from the supine position, or turning sideways.
Yeah, so difficulty in turning in bed is an important pointer that the patient may have the trunk muscle weakness. And what about the neck muscle weakness? Because at times when there is an high cervical compressive myelopathy, the neck muscle weakness also points to a higher myotome than just a C5, C6. So how will you take an history of neck muscle weakness?
Patient will usually have a complaint of either a side to side or a flexion movement. A typical yes or no type of movement will be difficult for the patient.
Usually,
so he'll complain.
Yeah.
Yes.
Go ahead.
He'll complain that he is not able to turn his neck when he receives a sound from the lateral sides.
You are partially correct. What happens is when the patient is rising from bed, his head lags. There is a head lag when he is trying to rise from the bed. This is usually the complaint the patient has.
Yes, sir.
So you should be knowing how to take a history, because ultimately the history will decide your level. Okay. And
yes, sir.
Then weakness of respiratory muscle. So not everyone will present with PANC, respiratory muscle weakness, and accessory muscles. So obviously difficulty in completing sentences, nasal flaring, and use of accessory muscles, all will point to a weakness of respiratory muscle. So this thing should be specifically asked when you are taking history of weakness. Then obviously associated spasticity is pretty important if it's an upper motor or a lower motor neuron weakness. And this inverted U-shaped pattern or an Alsberg phenomenon, in which this is again related to the topographical arrangement of the fibers and the decussation at the CV junction. So from where the compression started and the way it's going will decide this pattern. So usually the ipsilateral lower limb, then the ipsilateral upper limb, then the contralateral upper limb, and the contralateral lower limb, if it's at the CV junction. And other than the upper motor neuron signs, which are obvious because of the spasticity and the exaggerated reflexes and the flexor spasm, you should always check in a spine case about any lower motor neuron signs. So why it's important? Because lower motor neuron signs will decide your vertical level. So if you say there is a disc at C5, C6, which is the cause of the cervical myelopathy, then there will be upper motor neuron size below the C5, C6 level. So you will have an exaggerated triceps, exaggerated knee jerk, exaggerated ankle jerk. But at C5, C6 level, there will be lower motor neuron signs. So if there will be something like a fasciculation around the deltoid region or a focal vesting in that myotome, that will point that the compression is exactly at C5C6 level rather than the compression being at CV junction or anywhere else. So the lower motor neuron sign is pretty important. So even in the dorsal spine, if you are taking maybe a mid dorsal OLF sort of thing, so at that level there will be a lower motor neuron sign, and below that level there will be upper motor neuron sign. So you should always try to find out if there are any lower motor neuron sign in a spine case. So even in the C5C6 disc, that if the biceps jerk is depressed and the triceps is exaggerated, or maybe lower jerks are exaggerated, that means that the C5C6, which is a depressed jerk, is actually the lower motor neuron sign at that level, and that is probably the cause of the problem at least the vertical level. Horizontal, then you will have to decide whether it's an intramedullary, extradural, or extramedullary. So this is, I just want to make your thinking process clear that this is the way you should approach a case. You may be wrong, but ultimately, but the thought process should be correct. That is what I meant to say. Then you should always be clear about myotomes. So what muscles, we are many a times clear with the dermatomes, that this is T4, nipple is T4, umbilicus is T10, and all those things. But myotomes, each what C2, C3, C4, C5, C6 till S1, you should know every if there is any motor innervation by that root, and that will be a pointer to your pathology at a focal level.
Sir,
yeah.
How much difference would it make to know a myotomal level and a dermatomal level in a given case? Say supposedly we have a C5, C6 disc. How does it help in changing our diagnosis or ordering an extra investigation like an MEP or SCCP or something like that?
No, it will always be supportive to your diagnosis. So what happens is sensory symptoms, unless they are present at a significant level, the patient also are very not very forthcoming with the sensory examination. At times they say ठीक है, उतना ही है, कुछ ज़्यादा difference नहीं है. तो at that time you will probably be more objective with a myotomal level, because the reflexes being depressed at a particular level and the all other reflexes being exaggerated below that level will definitely be a more sure pointer. So it is additive rather than exclusive. So you should know that it is at times useful. But obviously we are told that the spine case diagnosis rests on sensory level. At times it is correct because that gives a clear cut way below which the sensations are gone. But at times when there is subtle sensory changes, then myotome can also help. So you should know that. So frequently we tend to forget the myotome. So what is the myotome? What C3? We take for example, we all know C5, C6, C7. But if you ask anybody what is the C3 innervation, and C3 innervate which muscle, then many of us won't be able to tell. So that's the purpose, that you should know that.
Okay. And sir, another thing I want to know, that while examining, if we have a different sensory level and a different motor level, so which one out of the two will be more accurate as far as level confirmation is concerned, the sensory or the motor?
So history is, hello, yeah.
Yes, sir.
So I will still like to means ultimately once you examine, then only you will get to know about the sensory level. We are talking about history now. So history wise, obviously you will have to take the sensory because the patient is telling the sensory. Till this time you haven't examined him. So the system works in such a way that the examiner expect you to diagnose a particular case based on history. So first, whatever the patient tells, you have to gather information from that and come at a clinical diagnosis, which may get modified after examination. Okay.
Okay. Okay.
So again, the next symptom usually is a the instability of gait or an ataxia, which can be at times due to sensory, the posterior column, or it can be cerebellar as well in a CV junction case if there is an associated carry malformation. So typical history is of wash basin ataxia. I think we have Arijit also with us.
Yes, Doctor.
Yeah, Arijit, can you tell us what is wash basin ataxia and why it happens?
Sir, when patients after washing the face, while washing the face, suddenly they close the eye and they feel imbalance while standing. So it happens mainly there is
normal. Sí, esto empezó entonces entre miércoles y jueves. Ajá, ayer cuando estaba comiendo me di cuenta porque comía.
Dr. Pierre, Dr. Mora, can you please switch off your mics, please? Yeah, Dr. Arjit, you can go ahead.
If there is any involvement of the dorsal column, so that can present as wash basin ataxia.
So why at that time only when you're
because the proprioception is involved, sir. When there is ataxia for the cerebellar pathology, cerebellar involvement, when the eye is closed, so the balancing is mainly will depend on the proprioception from the joint, muscle, and other position sense. So that is impaired because of the dorsal column involvement. So that's why we see this kind of ataxia there, sir.
Okay, so there is always a visual compensation in this sensory ataxia, and when you're actually putting closing your eyes, this visual compensation is also gone, and then this become manifest. So yes. You should know how to differentiate between a sensory ataxia and a cerebellar ataxia. Obviously, there will be disproportionate increase in the dark, difficulty in coordination, and other associated cerebellar signs. Like, can you enumerate some of the cerebellar signs you know of, which can be
from head to toe? If I look into it, sir, from nystagmus, then going downwards, dysmetria, dysdiadochokinesia, we have an involvement truncal ataxia or appendicular ataxia, then pendular jerk, rebound phenomena.
Yeah, so you know, so dysmetria, dyssynergia, dysdiadochokinesia, intention tremor, fast pointing, so many things, and you should be knowing this thoroughly because these are usually need to be examined clearly in CV junction, a bony CVJ with a KRE malformation, and you should know all these things. So if there are associated cerebellar signs present, then obviously you should always think about cerebellar ataxia as well. Then again, the same pattern has to be followed: onset, duration, progression, aggravating relieving factor, current status, current disability, and that will actually give a very good impression to the examiner that this guy knows how to correctly take the history. Then the sensory complaint. Again, there are mainly two tracks: the dorsal column and the spinothalamic. Dorsal column touch, fine touch, and all those things. Spinothalamic, temperature and pain. And in CV junction and on the higher cervical cord, even the spinal tract of the trigeminal can also be involved. So, Arijit, do you know till what level the spinal tract of trigeminal can descend in the cervical spinal cord?
C3, C4 level.
Yeah, so that's pretty important. So in a CV junction, even the fifth nerve symptom can be there, and you should be asking this very clearly. That will give the examiner that this guy knows this. Okay, and obviously spinothalamic, how to take a history of a spinothalamic tract is of the differential sensation during bathing, and all those things, pain, temperature, whether it's affected or not, and you have to take it correctly. And like this, any difference of during of water, perception of water while bathing, any area of numbness. And posterior column will usually present, as we had discussed, with wash basin ataxia and a cotton wool feeling of if the patient says that मुझे गद्दे पे चले जैसा लगता है, that means that his posterior column is involved, because that's a typical sensation which a posterior column, if they are affected, the patient will tell. Then these are mainly, we discuss the pain, we discuss weakness, we discuss the sensation, and because these are the primarily the presenting complaints. At times you have to, in addition to whatever the patient tell, you have to take history about associated soft tissue CVJ anomalies or complications. What I mean by complication is, if there is a CV junction anomaly, there can be serings, and purely extradural pathology is now complicated by intramedullary syringomyelia. So there will be an overlap of symptoms, and that's why you should always ask for it. So what will happen if there is a syringomyelia? There will be some differential change in the symptoms. There can be bladder bowel involvement. There can be an associated hydrocephalus. If there is bladder bowel involvement, you should be able to differentiate between whether it's an upper motor neuron type of bladder or a lower motor neuron type of bladder. So how will you, Arijit, can you tell us the cardinal features? How will an upper motor neuron bladder present?
So,
Arjit, you can go on.
mainly the bladder innervation of the sacral in origin. So also upper motor we can see mainly parasympathetic involvement to the bladder. The bladder contraction will be impaired. So there will be difficulty passing the urine and urinary retention because relaxed, and parasympathetic activity will be affected because of the upper motor neuron involvement.
So how will the patient present if there is an upper motor neuron bladder?
Urinary retention.
No, that's not correct. So Kevin, you want to answer this?
Yes, sir. Patient will have complaint of frequent increased frequency, it's called as urge continence and detrusor synergia, detrusor sphincter dyssynergia. So he'll have an incomplete sensation, incomplete voiding, and repeated number of times he has to go to void. So that will be his complaint.
So you have to remember it like this. If there is an upper motor neuron type, there will be frequency, urgency, and urge incontinence. Frequency, urgency, urge incontinence is usually upper motor neuron bladder, and overflow incontinence is actually the lower motor neuron type of bladder. So there are other bladders, spastic bladder, atonic bladder, and bladder is itself a huge topic, and you should read everything about it, the innervation, the hypogastric, the local reflexes, everything. But by and large, this is the broad differentiation. Frequency, urgency, urge incontinence is upper motor neuron. Lower motor neuron is usually the overflow incontinence. Okay, so read about the bladder from De Jong or Bickerstaff. It's very well given. Okay. Then, in addition to the other complication can be an hydrocephalus, so you should always ask for headache, vomiting, feature of raised ICP. How will the headache of raised ICP present early morning? Headache relieved by vomiting, increase with coughing. Okay. Then other than these positive complaints which the patient is telling you, you have to take out important negative history. and what is those important negative history which you have to elicit from the patient is history of other cranial nerves which can get involved. So, Kavin, can you tell us what all cranial nerves can get involved in a CV junction anomaly? Because this is
Yes,
a
sir.
very frequently asked question during exam.
Yes, sir. The trigeminal nerve, the ophthalmic division of the trigeminal nerve, and lower cranial nerves, which are 11th, 12th, and 10th, can get involved.
So you are saying trigeminal and what? Lower cranial nerve, which?
Lower cranial.
9, 10.
10, 9, 10, 11.
Okay. Arijit, do you want to add to it, or these are the cranial nerves usually involved?
Yes, sir. I think.
Okay.
Yes.
You feel no other cranial nerves are involved? So,
Yes.
as per various published literature, if there is hydrocephalus, there can be involvement of the second nerve. There can be a involvement of the sixth nerve. Spinal tract of trigeminal, fifth nerve we already discussed. Okay. Eighth nerve. In Menezes paper, lot of patients had eighth nerve involvement as well. Then 9th, 10th, 11th, 12th, all can get involved in CV junction. So right from 2nd, 6th, 5th, 6th, 8th, 9 to 12, all these can be involved. So you should know this.
Okay, sir.
And
then
Nazar, can you switch off your audio, please?
Sachin boss, Dr.
Yeah.
Sachin.
Yeah.
Hello, Dr. Sachin.
Yeah. Go ahead.
Sir, you are the host. You can mute everyone except you gradually, and then two candidates. You three just. You are the host, so can you do that, sir?
I tried, Jayesh, but I couldn't. So that's I given the rights to Rishabh.
Okay.
But he also was not able to do that.
I'll do one thing, sir. I'll reclaim the host once more, and I'll do. Yeah. I'm sorry for the interruption, sir. Yes, sir.
Yeah, good. Thank
So,
you.
did you make mute all?
Yeah, I've muted everybody, sir.
Okay.
As of now. Yeah.
Okay. Then this.
Yeah,
okay.
Sachin, sir, you're the host again.
Yeah. So the important negative history you have to take out, and that will give the examiner again the confidence in the student that this person knows what to ask, and that is very helpful for you as you progress in your exam. So the next negative history which you should ask is again history of tuberculosis in India in spine is pretty important. So anything which is extradural, like you are thinking of an extradural pathology, you should always ask their history of pneumoptosis, past history of TB, or all those things. Very important cause, because TB can present in myriad ways and it can be a cause in any case. Okay.
Sachin, sir.
Yeah.
Dr. Sachin, can I interrupt?
Yeah.
Sorry. We are very glad that we have Professor Atul Goyal sir here also. And yeah, so we should take their comment also before Dr. Sachin moves ahead before the negative history. Sir, can we have your comment, sir? Guide us regarding the spinal case evaluation. You are mute, sir. Sir, you are mute. Rishabh, unmute.
Sir. Yeah, I'll do that, sir. I think, sir.
Yeah, can you hear me now?
Yes,
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 Yes, sir.
yes,
Yes,
sir.
sir.
Yes, sir. Yeah. Good evening, sir.
Good evening to everybody, and I'm very happy to see all. I should call them young because I'm not saying I am old, but I am also a part of the learning process. And really, I feel very strong and very energetic when I see young faces. And I must tell you that this kind of learning process is great, and I wish that you all continue with this project. And I can see that Jayesh is participating, and he's our now new
Mumbaikar.
new face of Mumbai, and he will project this face to the world. As far as Sachin, whatever Sachin is, he has prepared quite elaborately in teaching young residents and young neurosurgeons how to examine a patient, how to learn from the patient, and how to give back to the patient. See, my most important thing is when we are examining a patient, we should become involved in the patient. We should know his problems. We should know his disability. We should know how his current situation is affecting his work, his profession, his daily life. When we are examining the patient, we should be completely involved in the patient. Like, for instance, he is not able to now perform well in the house. He's not able to walk in the house. He's not able to go to his work. He's not able to climb a bus, which he was able to do earlier. He's not able to eat with his hands. He has to be fed. So, examining of a patient is one thing, and getting involved in his life is another thing. So when we are examining the patient, all the things that we examine, all the things that we ask him in his history should be so complete that there should be no need for neurological examination to that extent. Like, for instance, if you are saying that he's not able to eat food with his hand, or he cannot break chapati with his hand, he cannot comb his hair, he's not able to do some kind of activity, you can assess his power of his fingers, of his elbow, of his shoulders. So, in the history, you can do quite a bit of neurological examination. Suppose you say he's not able to walk. So you know exactly what his level of power is. Suppose you can examine him and ask him about various sensations, as Sachin was mentioning. And you can get his complete sensory examination from the history, like his posterior column dysregulation and all those things, like you were saying, about his urinary symptoms, about his bowel symptoms, about his power. Exact power you can find out from your examination, from your history. So you know what, the history taking should be so complete and so elaborate that from the history you should be able to tell what grade of power is there, what sensory dysfunction is there, what neurological dysfunction is there, what cranial nerve deficit is there. So that is one thing. So one, from the history, you have to be absolutely, elaborate. And then you do an examination of neurological function, and then you come to a diagnosis. And when you come to a diagnosis, your diagnosis should be so perfect and so complete. Like you say, it is a C5, C6 level degenerative disease. Or you should say it is cranial-vertebral junction disease, or whatever. You should be not only pointing the level, but by your history and by your examination, you should be able to give the disease that he has, like craniovertebral junction, Chiari malformation, craniovertebral junction with syringomyelia, craniovertebral junction with other problems. So, and deformities, whether, in the history, you have to ask whether there is some spinal deformity. Like if there is a craniovertebral junction, there may be scoliosis, there may be torticollis, there may be short neck. So the history should be so much that there may not be any need for any kind of examination. So this is my just a smallish little message. And I must tell you that I'm watching you and I'm learning from you. And all, when we are students of neurosurgery, one thing is for sure, we should be completely patient oriented. We should, when we are presenting in the examination, for instance, if you are giving your history in the examination, you should be so much involved in the patient's clinical condition, his household activity, what he is not able to do, and say to the examiner that this guy is not able to do this thing which he was able to do yesterday, in a very positive manner. So I have a feeling that history taking is very important. Neurological examination is another important. Then investigations are important. And then coming to a diagnosis is so important for any cervical case or lumbar case or for brain tumor case. You should be able to tell that this is a 4 centimeter acoustic on history. You should be able to tell that this acoustic is compressing the brainstem cranial nerves and causing hydrocephalus. So in short, I'm saying that history taking is absolutely important, and history should be taken very elaborately and should be completely patient-oriented. Jayesh, further to you.
Thank you so much, sir. All the words and all the sentence will be like dictum for neurosurgery in the world, and that is not by me, that's by all the residents who would be agree with us, including Dr. Sachin. And absolutely true, the history taking, as Dr. Sachin has very nicely explained us and teach us that on the base of history only you can exactly pinpoint the track that what is going on within the spine. So thank you so much, sir, for your wisdom word. And please stay with us because Dr. Sachin has so many things more ahead. Sir, Dr. Sachin, please.
Yeah. Thank you, sir, Dr. Goyal, for your inputs. Obviously, what sir is saying is again getting involved with the patient is again telling his current status and current disability, which previously he was able to do. So again, this is pretty important, and that gives a very positive message to the examiner about your involvement with the patient. So that these soft skills are pretty important even during presentation. Okay, so we move ahead.
Yes, sir, you're already the host.
Yeah. So for any pathology, you should always take history of etiology. So what can it be? It can be an extradural pathology at the CV junction. If you are thinking, you should always divide your etiology in trauma, infection, congenital, and neoplastic, and try to take history, negative history. If there is no history of trauma, there is no history suggestive of an infection, like TB we already discussed. Then tumors will be insidious and all those things. There are other, something like a neurofibromatosis or a foramen magnum neurofibroma can also mimic a CV junction anomaly presentation, like a high cervical presentation, high cervical myelopathy presentation. So you should always ask history of etiology in any case, not just spine, even in brain. You should always ask history of etiology. Then for CV junction specifically, as you know, it can be associated with multiple syndromes. So syndromic CV junction anomalies are pretty common, and you should always ask for syndromes. And Kavin, can you tell us some of the syndromes which are associated with CVJ anomalies?
One of them is Klippel-Feil syndrome, sir.
Yeah.
Patients with neurofibromatosis can also have CV junction anomalies.
Yeah, neurofibromatosis is less likely. Other syndrome.
Dr. Arijit, if you would like to add into it.
Neural tube defects.
Which is there any syndrome you wish to tell, or what? You wish to tell that if the patient can have a neural tube defect below as well. Is it something like that? So
yes, sir.
There are other syndromes like Downs is one important cause. Klippel-Feil, obviously you have to ask. Then there can be Marfan, spondyloepiphyseal dysplasia, Morquio syndrome, mucopolysaccharidosis. Hundreds of syndrome are there which are associated, but mainly you should focus on Klippel-Feil, Downs, Marfan's, because these are more common. Okay, so you should be knowing what is in history which will suggest that this patient is a patient of a Marfan syndrome having a CV junction anomaly, or a Down syndrome, or Downs is obviously easy to diagnose by this particular facies and all those things. But at times you should read about Marfan syndrome as well. You should know all the components of Klippel-Feil likewise. Okay.
Yes, sir.
Then obviously we discussed this congenital traumatic infection and tumor, and you should be able to pinpoint one cause out of them for your problem. Then coming to the current status and current disability, what Dr. Goel very well mentioned, that the patient is able or unable to feed himself independently. There is problem with his daily living, like buttoning, unbuttoning has become increasingly difficult. He is not able to walk independently. He is not able to sit cross-legged, and he has problem with carrying out activities of daily living. And everything has to be told in the end that because of all this problem, he is facing so much of problem. And past history, and this is for the sake of completion, but TB again is important. Personal history, menstrual history in case of female, this is all for the sake of completion. Family history again is important as far as syndromic association are concerned. And treatment history is usually they may have been referred to you. The patient may already been advised a collar or something like that. So this should be for the sake of completion. You should finish, and if there is any long-term steroid use or drug use which can have implication to your treatment, or antiplatelet drugs and all those things, that is treatment history is important for that. So perioperative management. So what happens is, this is an half an hour or 45 minutes of your presentation, which usually no examiner interrupts you. They are quietly noting down the points which you have already told, and trying to figure out what's going on in your mind. So this 45 minutes is your attempt to make them think in a particular way. So you should try to present in such a way that everything is pointing to one direction, that you are taking everything to maybe an extradural compression at the CV junction, and you are probably trying to point out that it's a bony CV junction anomaly, something like that. So all this history should, if that approach is there, then obviously the examiner is pretty much for passing you in exam. And most of the people are passed or failed in history. So you should be extremely thorough with your history. So history will pass you, long case history. So then what happens is, they will say now enough of treatment and all those things, just summarize the history. So summarizing is a one para, you have to summarize the entire whatever you told in a concise, proper scientific way, that list out the chief complaints which you told, and describe in such a way that something like, which should be self-explanatory and points to a particular pattern of involvement. Like I'll tell you, what if I have to present, I will say that this 45-year-old gentleman presented with a progressive ascending spastic quadriparesis, which started from the right lower limb, ascended to involve the right upper limb, then the contralateral upper limb, and then the lower limb. So what I mean by this entire sentence is, it's an extradural compression, which has extradural or extramedullary compression, which has involved first the sacral fibers, then the cervical fibers, then the opposite cervical fibers, and then the sacral fibers. And it's a spastic weakness. It's an upper motor neuron type of involvement. It's an asymmetric weakness which started from one side and involved the other side. So a lot of things are clear in this. So you have to tell each complaint in in this way. If you have to tell a sensory, then again that patient has a graded sensory loss or feeling of less sensation below the C2 level for all sensations, and he associated with cotton wool feeling while walking and wash basin ataxia. So again, that will tell that the patient has posterior column involvement. So this is pretty important, and on your history, you should be able to diagnose an extradural or an intradural pathology, whether it's an extradural or intradural extramedullary or an intramedullary. So for the pointers again is the cross-sectional diagram. So intramedullary will have a descending type of weakness, a different early bad blood involvement, and more upper limb involvement compared to lower limb. So all these things should be known, vertical level and horizontal level. So many a times after you summarize the history, what the examiner will ask you to draw this cross-sectional diagram and tell us exactly where is your lesion lying. So this cross-sectional diagram will be there with you for your entire case. So you should know where to exactly pinpoint, so that this is the starting from this side, right side, extradurally, this is compressing the corticospinal tract first, then it is compressing the autonomic fibers, and so on and so forth. So this is important. That is the horizontal level, the extradural, intradural, extramedullary, and intramedullary. Vertical level again will have to be narrowed down. At times you are able to diagnose that it's a high cervical compressive myelopathy above C5, but you are not able to pinpoint whether it's C1, C2, or it's a C3, C4, or it's a C5. Then the things, these particular pointers which already we discussed, the neck muscle weakness, the hypostasia in the nape of neck, which is actually because of the C2 nerve, and all these things will come into picture, which will elevate your level from so-called C5 to maybe C2. Then lower cranial nerve involvement will again be not present in a C5 lesion, but it will be present in a, obviously, the cervicomedullary lesion. So that will that's vertical level, and the importance of vertical level, which I emphasize, the importance of the lower motor neuron signs at a particular level, which will point to the lower motor neuron involvement, and that will tell you the vertical level. And complications which we already discussed, if it's associated with a Chiari malformation or a syringe or a hydrocephalus, and etiology. So probably I feel that it's a developmental CVJ anomaly, or I feel it's a tumor at the CV junction, or I feel it's a neoplastic, whatever you feel as per history, you should be able to tell in this summary. So this summary is extremely important, and those who haven't listened for 45 minutes will surely listen this summary of 5 minutes, and this is one final chance you have to impress the other examiners. Okay. And obviously then based on your involvement, you should know all these things. The spinal cord level is different from the vertebral body level. So if you are diagnosing maybe a D8 myelopathy, then that is this spinal segment. So the vertebral level will be higher. So you should know this, that as per the level of the spinal segment, you have to subtract the number of vertebral bodies from that. Okay. And very favorite question, at times a short case, you will get something like a conus cauda lesion, and then epiconus. What is epiconus? What is conus? What is cauda? How to differentiate between that will be thoroughly asked. So many a times a spine case is given something like an intramedullary dermoid, or maybe a lipoma at the conus is given as a short case, and then this epiconus, conus, and cauda is asked, and many of the residents are pretty much confused in all these things. So you should read thoroughly about it. Again, the cardinal signs and symptoms. Arijit, can you tell us the cardinal sign and symptom of extradural pathology?
Sir, vertebral pain, mechanical kind of pain.
Other than that, anything else? So pain is a very universal symptom. So in spine, so usually pain brings you the patient to us. So the pain alone is insufficient to say that it's an extradural pathology. What else? Kavin, do you have something to add?
It would be a radicular type of pain. There will be an asymmetrical weakness which the patient present with, or an yeah, that will be asymmetrical. Sir. The sensory symptoms will be delayed. The motor symptoms will be present. Will be the initial complaints followed by sensory.
So
the bowel bladder involvement will be late.
Yeah, that's right. I'm asking you the cardinal symptoms, and these are the cardinal symptoms. If it's an extradural pathology, it should be pain, tenderness, and deformity, which is usually present in an extradural pathology. If you believe that it's a TB spine, there will be, if you do a local examination, there can be tenderness as well. There can be a knuckle, something like that. Even in torticollis is a form of deformity. So they are mainly extradural. So pain, tenderness, deformity is the hallmark of an extradural pathology. Can you tell us if how can an intradural extramedullary, what can be the cardinal sign and symptom?
Again, it can present with an asymmetric weakness and radicular pain.
Yeah, asymmetric, but it's more of a brown Sickert type of syndrome. What happens is it is starts from one side, maybe a neurofibroma arising from a particular root, and it actually causes compression of that half of the spinal cord. So it usually presents with brown Sickert. And what is the component of brown Sickert, Kavin?
A patient will present with a contralateral motor weakness and ipsilateral pain and pain temperature weakness loss.
You are flipped it. It will be ipsilateral motor loss and contralateral pain and temperature. Okay, so ipsilateral posterior column and ipsilateral corticospinal tract will be gone, and the contralateral pain and temperature will be gone. Okay,
yes.
So
yes,
this
sir.
is usually suggestive of an intradural extramedullary. And what about intramedullary?
Funicular type of pain and early bladder bowel involvement and dissociated sensory loss.
Yeah, very good. So poorly localized funicular or dysesthetic pain. Patient is unable to explain the pain. It's like vague kind of pain. Early bladder bowel involvement. Upper limbs are more involved because again the topographic arrangement of the fibers, descending sort of weakness, and autonomic involvement earlier. So this is you should know by heart extradural, intradural, extramedullary, intramedullary, and this will be 100% asked in a spine case. So you should read more about it. Okay.
Yes, sir.
Yeah. So this is what is in the tabular form, and this is a very frequently seen in the books. The asymmetrical will be extramedullary, symmetrical, intramedullary, and all those. We already discussed this. So finally, you will have to make a clinical diagnosis, which should include all these things. What should be the nature? What is the nature of the lesion? Whether it's a myelopathy, a radiculopathy, or a myeloradiculopathy. Many a times you may get a short case of a cervical disc, in which the patient is only having a radiculopathy rather than a myelopathy. So you should be able to do diagnose it correctly that it's not a myelopathy, it's just a radiculopathy, or it's a combination of myelopathy and radiculopathy. Vertical level, and we already discussed high cervical, low cervical. You should ask for the C2 hypoesthesia, the neck muscle weakness, everything above C5. And horizontal level, we discuss extradural, intradural, extramedullary, intramedullary. Complication, bowel, bladder, raised ICP, syringomyelia, all those things, and probable etiology, what you feel. So I would like to diagnose the clinical diagnosis. I feel it's a high cervical compressive myelopathy, most likely a bony craniovertebral junction anomaly, which is causing an extradural compression without any complication like syringomyelia or raised ICP. Most likely is a developmental pathology. The first differential diagnosis I would like to keep is a developmental CVJ anomaly. The second can be 1, 2, 3, and it can be a foramen magnum meningioma. It can be so on. Okay, but the highly probable diagnosis should be kept first. Like in a CP angle, you will always say that I feel it's a CP angle pathology, most likely a vestibular schwannoma, then a meningioma, then a epidermoid cyst, and all those things. Similarly, here also you should, as per the frequency of occurrence of such pathologies, you should make a differential list and always keep it ready. Okay.
So this is quite summarizing, sir. Can we just take for the audience, can we take just one example? Since Arjit had prepared one case, we'll just focus on the diagnosis. How does he make the diagnosis as you've elaborated? So Arjit,
I think Arijit, once now you know what points have to be grabbed on the history to make a diagnosis. So based on your history, you can go ahead quickly through your history and tell us in 10 minutes, and just try to diagnose based on this, and we'll see whether you are able to do that and whether this has been useful to all of you.
Just keep it short, very short. We will like to concentrate more on the way Sachin sir has described. This should be a clinical diagnosis. We would like to concentrate more on that.
Okay, sir. Sir, I have a brief presentation on 3-4 slides. Can I share my?
Yeah. Please.
Okay. I'll just make you the host, Arjit.
Yes. Thank you.
Arjit, you are the host now. You can share your slides.
Okay, thank you.
Yeah.
So briefly presenting my patient, Mr. A, 58 year old, right-handed businessman by occupation, formally educated, speaks Bengali and Hindi fluently, history given by himself and is of good reliability. Presenting with chief complaint of numbness of both the lower limbs on walking since last 6 months, and pain on both the legs on walking since last 6 months. The complaints are insidious in onset, gradually progressive in nature. That for 6 months back, there used to be pain after half an hour of walk, and progressively start after 5 minutes of walking. But presently it's moderate to severe in intensity that he cannot tolerate it. Pain is dull-aching in nature, while with feeling of tiredness and tightness of the buttock, thigh, and legs. Numbness is such that he doesn't feel any sensation on legs, mainly in the buttocks and the back aspects of the thighs, legs, and the foot and the toes. Symptoms are aggravated by walking straight and relieved after 5 to 10 minutes of sitting or bending forward. So there is also history of occasional lifting of heavy weight for his daily work at shop or as he's a businessman. There is no associated history of any limb weakness or any chronic back pain, no history of trauma, no history of similar complaint in the past, no similar complaint for the upper limbs, and no history of any bladder valves problems like urinary retention, urgency, or increased frequency, or incontinence, or constipation, or stool incontinence. No history of neck pain, no history of imbalance while walking, no history suggestive of any sensory disturbance in rest or in sitting or lying down position. The present status of the patient is severe to the pain or symptom is such that it is affecting his daily life. Summarizing, Briefly, 58-year male, businessman by occupation, presenting with progressive dialectic pain and numbness of posterior aspect of both the lower limbs on walking since last 6 months without any motor deficit or autonomic involvement. Based on that history, I would like to consider the substrates involving bilateral L4 to S1 roots as dermatomal distribution of posterior aspect of lower limbs or foot. Clinical diagnosis, I would like to consider neurogenic claudication. Pathology, I'll think of lumbar canal stenosis. Etiology, mostly degenerative, could be because of disc, ligamentum, facet or bone pathology. A level, most probably L3-4 on the vertical level, central or paracentral disc or central canal stenosis, or L4-5 if also there is lateral foraminal stenosis. Examination, the relevant examination, there was no deficit. Sensory examination was normal. Dependent reflexes 2+. SLRT was normal full. Gait was normal. Spine range of movement, there was no restriction. On dynamic testing, after 5 minutes of walk, right external hallucis longa EHL was mild weak. There was no tropic change in lower limbs. Peripheral pulses were well palpable. No tenderness, spinal or paraspinal. No step deformities. No scoliosis on palpation or inspection.
Yes, sir. Sachin, sir.
Okay.
Would you like to comment?
Kavin, what do you, if you had presented this case, would you have done anything differently, or you feel something can be modified?
I would also have done a leg raising test, sir.
That's examination. We are targeting first diagnosing it on history. So don't get carried away by examination, because most of your fate is decided during history. If you're going to pass, fail, whatever is decided in history. So concentrate on history. Number 2, it's a very at times, if you are giving an in-house exam, you have access to all the MRIs and everything. Never see the MRI before you are actually doing history part. So that will mislead you enough, and you will try to fit in your as per the MRI, and you will end up creating mistakes. So go with an open mind and try to diagnose. Even if ultimately it turns out to be a different pathology, doesn't matter, but the approach is important. Whether but I assure you, if you follow a systematic approach, you will be able to diagnose it correctly most of the times. So
Arijit.
Yes, sir.
Can you go again with your slide, please? Just, I want to make some.
So what Arijit has to actually tell is whether it's a radiculopathy or a myelopathy, obviously, and he has to on history pinpoint that this is L4-5 radiculopathy probably, which we are dealing with. Again, it is not just the differential. Then he had to differentiate between a vascular and a neurogenic claudication. Number 2. Number 3, why it is not a tumor which can present in a similar way. So you have to take out history excluding that. So all this could have been added to make it a bit more comprehensive. Now Jayesh, you can add.
Just want to add 2-3 points. Can you again share your slide, please?
Yes, sir. Yes.
Because some basic mistakes you have done that you should not in the exam. Go to history. Right. So always try. See, history. The main chief complaint is very important here. See, numbness in both lower limb on walking. See, here it's very important. Numbness and pain exactly where, particularly in all spine cases. Right. It's very rare that patient could say that, oh, पूरे घुटने के नीचे कुछ समझ में नहीं आ रहा, पूरे पैर के नीचे नहीं. So medial aspect of thigh, is it lateral aspect of thigh, is it medial part of thigh, it is radiating to the toes, right? This should be mentioned. That is number 1. Next slide. So exact dermatome should be mentioned in the chief complaint. Your clinical diagnosis you have made is the neurogenic claudication. Neurogenic claudication is symptoms. It cannot be a clinical diagnosis. Here, as Dr. Sachin told, based on your chief complaint and your detailed history, you should say L4 or L5 or S1 radiculopathy, unilateral or bilateral, right? That should be your clinical diagnosis.
Yes, sir.
You have made na clinical diagnosis neurogenic claudication. That should not be there.
Okay, sir.
Okay.
Yeah, so this case, even if it comes, will come as a short case, and short case people are not very much after your life as far as the history is concerned. They are more concerned about how you manage this case. This is usually what, as an examiner, I expect that a short case, फटाफट history बताओ और diagnosis बताओ. So then you will say, sir, I feel that it's a L4, L5 radiculopathy, most likely because of a disc.
Dr. Sachin, you are mute.
Yeah, sorry, I'm sorry. So I mean to say this will be a short case if it's there, and usually in short cases, the examiner expect you to tell the brief chief complaints and a clinical diagnosis directly, and they are more focused or more interested in knowing how will you manage that case. So, but long case obviously is the most important part of your needed for your passing, and that should be thoroughly presented and thoroughly clinical diagnosis should be made based on history as we discussed. Okay, so next time, whenever you are taking a spine case, try to incorporate these things in your daily the workups which you are doing for your patient, and probably by the end of by the time you appear for an exam, you will be sufficiently trained to take a proper history. So I will just quickly go through the examination points which needs to be covered, and then we can open the house. Is it okay, Jayesh?
Yes, definitely.
Yes, sir. Yes, sir. We'll complete it off. Yes, sir. Yes, sir. You're the host now.
Yeah. So then this is the diagram which I already told you that they will ask you to make something like this, and then you have to tell exactly where is your pathology. So you should, this diagram you should practice multiple times, and at least these three tracks, the posterior column, the lateral spinothalamic and the lateral corticospinal, you should be able to draw well with the topographic arrangement, and this gray column and all those things, and where exactly is the pathology you should be able to tell. Then the general physical examination, we are usually, as neurosurgeons, we are more interested in the neurological examination, but in any spine case, or for that matter CV junction, which is a long case, this general physical examination is also very important. And if you tell this at the start of your examination, obviously it creates a huge impact on the examiner that this person knows. So syndromic phenotypes like Klippel-Feil, short neck height ratio, low hairline, all these things should be asked, and you should know the exact criteria of when is it called a low neck height ratio, or what is the normal ratio, what is short neck, what is low hairline. Then autonomic system, bladder bowel is not the only autonomic system. There are others like skin changes, trophic changes, postural hypotension. So how to diagnose a postural hypotension? What should be the difference in the BP in the supine and the standing position? You should know this. So there is a very good chapter in De Jong about autonomic nervous system, and it gives everything what needs to be asked and what needs to be examined for autonomic nervous system. So you should read that. Then neurofibromatosis is a very common syndrome associated with spine, and the tumor can present anywhere. So neurofibromatosis features, you should know the major criteria, the minor criteria, all those things. Then this other system examination, respiratory is pretty important because all the problems are then it affects the respiration. So single breath count, breath holding time, are and a very good pointer for need for ventilation or the involvement of the medulla or something like that. So single breath count, normal range, breath holding time, normal range, you should all know. CVS, at times, if you say people will, the examiner can ask you what do you expect in CVS in a CV junction. So you should be able to know that there can be murmur, there can be aortic regurgitation in Marfan syndrome, there can be diastolic murmur, something like that. So you should know the theory part. It may not be present, but obviously you should have to give an impression that you know. Then stance and gait are again important for any spine case, which is frequently missed. You can diagnose a patient coming to your clinic by
Dr. Suresh, can you please mute your audio, please?
So
sorry, sir, for the interruption.
Yeah, no issue. Then stance and gait. So an antalgic gait or a scissoring gait, everything points to something, and you can diagnose a lot of things based on gait. So gait again has a lot of components, and it's a separate topic. So gait and station is one chapter which you should at least read during your preparation. That will give you more insight on this. Okay, then syndromic CVJ I already discussed. So Marfan and Klippel-Feld Downs, you should know everything about them. What are these? What will be the phenotypical markers in a Klippel-Feld syndrome? There can be webbing of neck, there can be low hairline, there can be short neck. Marfan syndrome, again the arm span, these Gaines criteria, arachnodactyly, many things. If it's a Downs, then the low set ears, hypertelorism, epicanthal fold, simian crease, and you just have to enumerate. If somebody asks you, and if that patient is having it, then obviously you have to tell that these all are present. But upfront telling all these things that I have checked for this will give a pretty good impression to the examiner. Okay. The neurological examination, then comes the neurological examination, and which should usually proceed in the usual way, which we usually do, right? Try to be systematic in this. Higher mental function first, cranial nerves, which start from the first and go till the 12th. And as we already discussed, what all cranial nerves can be involved, and you should specifically mention when you're examining the fifth that as per examination, there is no involvement of the spinal tract of trigeminal, there is no onion peeling, whatever. Tell such buzzwords which actually creates an impression. Okay. Then motor again has to proceed in the usual way: tone, bulk, power, reflexes, superficial, deep, and all those things. And then sensory, then cerebellar, and then the local spine examination should also be a part of your history. So motor we already discussed: tone, bulk, power, reflexes, superficial, and deep. You should know all the root values, which are all superficial reflexes. What is the grade of reflexes? What is clonus? What is hyperreflexia? How to elicit an ankle clonus? How to elicit a patellar clonus? What is ill-sustained clonus? What is well-sustained clonus? Everything can be asked, and many a times you will be asked to perform one of these things, like do maybe a knee jerk, and you should know the exact way. Check the books how it is done, how to distract the patient, what is Jendrasic maneuver, how to reinforce the reflexes. If there is no plantar, then what are the other ways to elicit plantar, the other method, the Gordon's method, the Oppenheim's method. All these are pretty favorite questions of the examiner, and you should know everything about it. So then the proper way to do that is also important. So how do you talk to the patient, whether you have explained that you are going to do to the patient. Like many times somebody asks the student that illicit knee jerk. So what he does is वो तुरंत उसका blanket खींचता है और सीधा knee jerk करने लग जाता है. That is not the way. You should actually communicate first to him that we are going to examine this and this. Then you have to cover him well. and the patient should be comfortable. You should talk some normal things with him so that he's comfortable, he's distracted. So otherwise you won't get a proper reflex which you want to elicit. And this also is this communication skill is also graded in your exam, that how you are communicating with the patient. Okay, so it has to be brought, means you have been listening to this since I think MBBS days, so nothing new in that, but I'm just reinforcing what is important. Sensory again should have a proper kit to test sensation, because sensation is a very difficult thing, because the patient are at times, it solely depends on the patient to tell you. So you should have the proper kit to how to examine the fine touch, how to examine the crude touch, what are the things to do, pain, temperature, what temperature should be there for cold, what should be for hot, how to examine joint position, vibration, what tuning frequency should be there to assess vibration, what is for hearing, what is for vibration. There are different things, and if somebody asks you why these are different frequencies, then you should know the answer. So I mean to say that there should be a proper kit to examine everything. You should have a 124 hertz, 512 hertz, different hertz tuning forks with you. You should have even in cranial cases, you should have things to test for olfaction. At times there are 3-4 smells which are to be tested. Then you should have for touch all these things, the wisp of cotton wool, the pin head, something like that, pain, temperature. This usually provided, the temperature is usually given by sisters in the ward, that hot and cold. You should know and should compare with normal area. So sensory will give you a horizontal level vertical level in many of the spinal cases. So like maybe a dorsal compressive myelopathy, you will definitely get a band-like sensation or a sensory impairment at D8, D7 or D10 junction, and then you will say that it's probably a D8 myelopathy. So sensory is important. And then the spine examination, you should always check curvature, deformity. Okay, I just forgot, after sensory, cerebellar is important, which we already discussed. Almost 20 signs are there, the pass pointing and all those things, how to do that, finger nose test and finger heel shin test and all those things. You should know all those things. And local examination, any spine case, always examine local curvature, deformity, tenderness. That will complete your examination part. And then final summary should now include, check if their examination has added some additional things to your diagnosis, and now what is your final diagnosis. So the examiner will ask you exactly the same question: has examination added something to your diagnosis? And now what is your final diagnosis? You were first saying that there are 3-4 differential. Now are you able to say that it's only this thing? So obviously something will be added in the examination, which the history you couldn't elicit, but you got it in examination, and you will tell that, sir, this and this thing is added, and my diagnosis is still this, or I think I would like to revise my diagnosis to this. Okay, then the next question is, what will you do in this case, and what investigation that means to, they will say, how will you manage? So management shouldn't directly jump to surgery. You will always say that I will like to investigate the patient first, and the investigation should start as simple as a small X-ray, dynamic views, then a CT and the MRI. If somebody asks you what is one investigation which would you like to do, you will likely tell that I would like to do an MRI if I have to do only one investigation. Otherwise, you will tell all these things. They can ask you umpteen number of questions on your X-ray. What is atlantodental interval? What is normal? What is abnormal? What is age-specific criteria? What is Chamberlain line, Wickenham's clavicle canal line, Powers ratio, ye ratio, wo ratio, sub. So these are all pretty very standard questions, and nobody asks beyond that. Then obviously they will by this time they will display the MRI, that this is thing, you were diagnosing this and you are correct that all this is a CV junction anomaly. Now what will you do? What surgery you will do? Then there can be another Pandora's box. What surgery? It can be posterior, anterior plus posterior. Then all discussion on that. What are the advantages, disadvantages? What are the steps, complication? All those things. And that if you reach till this point, probably you have passed the exam, because otherwise most of the people get derailed in history. So this is the way an exam is conducted in MCH or DNB, and this is the way I think I would like each of you to practice in your daily routine, so that in exam it is just like another routine daily case and not an exam case. Okay, thank you very much. If you have any question or Jayesh wants to add, Dr. Goel wants to add, yeah, it's over to them. Yeah.
Thank you so much, Dr. Sachin. You have teach us so nicely about all the spinal evaluation points, how to clinically diagnose and how to reach the final summary and how to do well in your examination. So just want to add that already has been mentioned many times. I think the neuroscience it cannot be manipulated. It is 100% scientific things. If you ask patient what is the problem, if he is asked there is something and there is something, I would suggest for purpose of clinical diagnosis, never manipulate the things. In India, people comes late once disease has been progressed so much. So there is high probability that patient could have 2 or 3 things together. So if you try to manipulate the history, your sick complaint, then you cannot reach to the proper diagnosis. So whatever it is, you just try to analyze, and if you can able to put a single diagnosis, or you can say that there is a coexistence. There may be canal stenosis, there may be cervical things, and then maybe tumor also, or added these things. So that is the very, very important thing in examination. And so Goel sir, you would like to add? I think must. So
any of the residents who would like to ask
question?
or interact or question? Arijit, would you like to change your diagnosis, reframe your diagnosis? Do you think the lecture previously that happened has helped you change your diagnosis in somehow?
Thank you, sir, for this excellent class. So so in organized manner we can know how to approach a spine case for cervical, thoracic, or lumbar pathologies. So definitely that helped a lot, sir, to understand it better.
So I think there is no question, and thank you,
there
Dr.
was
Sachin.
one question previously. Yeah. I think, sir, you've answered. We'll also take an opinion from Borkar, sir. Sir, the question was from Dr. Sagar Patil. Is Sagar online?
Just 8 now in CV junction anomaly.
Yes.
Reasons of 8 now in the CV junction anomaly.
Yeah, actually, frankly speaking, this is the paper by Menezes, and in which they said a very high percentage, the most common nerve involved in CV junction anomaly was 8 nerve in that series. And it has been a landmark paper, so oft quoted and oft asked. So you should know it can be, obviously, there can be multiple causes to this. People say there can be a coexistent otosclerosis there. Some say brainstem distortion, some conduction abnormality with the brainstem. So there are so many causes which are speculative, but in practice, I do not find it very often that the patient with CV junction has a 8 nerve involvement. But in examination, obviously, in an exam case, you should know that the examiner will expect you to know this, that in a Menezes series, 8 nerve was the most common. But clinical practice, which we operate so much of CV junction, I do not routinely find this. And even if you do a PTA or audiometry, there is hardly any problem even such patient. There has been numerous studies done in Indian setup in which people did PTA on a CV junction patient and it hadn't find much of a problem. But yeah, it can happen.
Very true. Yeah. So if no
Thank
further,
you. Thank you, sir.
no further question, Rishabh, can we end the things?
Yeah, I'd like to thank Borkar sir. Thank you for taking out your precious time, sir, and helping us formulate a diagnosis. Mainly understand the approach to a spinal case. Before we end, can we have all the participants switching on their videos so that we can have a small picture taken up?
Thank you, Kevin and Arijit.
Thank you very much.
Yeah.
Thank you, sir.
You have done very great job.
Yeah, very good.
Thank you, sir.
So just try to inculcate this habit of taking a history in this particular way, and I hope it will be useful to you.
I'm sure,
Thank you,
sir, it would be. I think the exams are due in a short time, so I think this was the perfect time to have a lecture series like this, where it has helped them clear it off. Many a times what happens is spine cases are, especially the lumbar spine cases, are kept up as short cases. So it is very important to have that the student should be able to summarize the entire history with an examination and help the examiner understand, the examinee understand that we have reached a diagnosis based on the history, so that the majority of the questions can be diverted to the treatment part and help the resident to pass. So thanks a lot, sir. I'd also like to thank Professor Jay Sardara sir to be the backbone behind this entire lecture series. So once everybody's video is on, we can have a small picture taken up. On the count of 3, I request Dr. Padam sir, Dr. Viraj, Dr. Vibha, Dr. Prakash. We have a few international candidates also today. Dr. Pierre. Yeah, so on a count of 3, 3, 2, 1. Cheers. We'll
Okay.
Yeah.
Thank you.
Thank you very much. It was nice, nice joining you all, and hope
Thank
to
you,
see you
Dr.
soon. Okay.
Thank you.
Thank you, sir.
Yes. Thank you.
Thank you, sir. Good night.